Okay, I will try to present you a treatment of recurrence of breast cancers. And just to memorize, this is my standard treatment schedule. It's 5 times hyperthermia, once per week, always previous the following radiation, about 45 minutes at least. And then within 5 minutes, I will giving 4 grays 5 times a week. That's all. So this is my standard fractionation. And if we go to the data, we could show that this fractionation at this schedule works. But we also know that size is important for the breast cancer recurrence, and it's logic, as larger the tumor is, then we have also higher probability to have a re-recurrence after this combined treatment, especially with lymphangiosis or with a cancer wIRAs. And the question arises, can we repeat such schedule in a re-recurrence? Just to figure a little bit the problem, this is a history of a patient, which I don't show you the picture, but a drawing. She had been treated first, 91, with cobalt treatment of a breast conserving therapy. Then she had a recurrence, mastectomy, chemotherapies, hormonal therapies, and so on. She was retreated again, and then she was again irradiated on the other side of the supraclavicular region. And we had now the question, how can we treat this locally again? So what I did is hypofractionated re-irradiation with wIRA-hyperthermia, and within 5 minutes an electron field. But it can happen that these patients are recurrent again. And can we repeat this local treatment? The solution could be this: again do wIRA-hyperthermia, large field, and again do electron field with this same fractionation. So what I will show you are the data of about 140 patients treated with this method, and 113 patients had a macroscopic disease. And you can also see that about 3/4 had a very large tumor extensions, more than 10 by 10 centimeters, or even a large amount of cancer wIRAs. So to obtain a complete remission is very important, but it's even more important to be sure can we also maintain this local control during lifetime. And you can see small tumors can be controlled better than large. And the cancer wIRAs, there you can never get any complete remission because the tumor is growing all over the body. But we can also see that we had re-recurrences in the complete remission patients in about 37% of all. And most of these tumors were on the border or outside. And we have 12 of these 19 patients repeated with the same treatment schedule. For the patients with partial remission, it's the same question. Partial remission is a good palliation effect in any way, but we have also to be sure that it will be maintained during the lifetime of this patient. And of course, we had a new local progression in a much higher rate than with the complete remission patients. Only 43% of the patients remained locally stabilized. But also for the cancer wIRAs, we have about 56% of the patients which were stabilized during the lifetime. And also again, for these recurrences of these 32 patients, 28 of them were repeated again with re-irradiation with the same schedule. So now it becomes a bit difficult because, of course, if I'm doing a retreatment again with the same treatment schedule, we cannot finish for all patients. So some of them had to be stopped due to the development of distant metastasis or rapid deterioration. But I have pointed out 2 schedules, 3 times 4 gray, and hyperthermia for the lymphangiosis is now become my favorite dosage, because I think less is more in this special disease. And most of the patients had a 5 times 4 gray again with hyperthermia, and you can also see how many complete remissions we could again obtain in these fields. So, and then we have some additional other attempts. The last 2 patients on this table with 7 times 2.5 or 10 times 2.5 gray, this was at the beginning where I was not daring to give the same fractionation as well, because they had really a recurrency within a short delay. So if we go back to the summary of all these patients, we can see that with the first re-irradiation and hyperthermia, we could already save, let's say, 63%, and with a repeated re-irradiation, we could again save about 11%. So it's in a way a salvage possibility. And I can show you some side effects. Of course, here we have in every case side effects, but how are the side effects? There are moderate erythema and hyperpigmentation in almost every patient, and also from the chronic part we have the same thing, a hyperpigmentation, and in some patients a new moderate telangiectasias as well. But no burns, no blisters, and no necrosis up the way. So it looks like that we can repeat this treatment again with this fractionation schedule. Some examples, here a patient I treated 2011 with a repeated irradiation with 10 times 2.5 gray, and 8 years later she was referred again to my department because she had a progression on her back, but you can see that she has lost the left breast due to another tumor, and she had been controlled on the right chest wall up to now. She has the price of telangiectasias, but of course there is no tumor activity for the moment on this part. This was a patient which I treated twice, because she had immediately after the first treatment again a progression sternally and where the clavicular region, and we have treated her again with the same schedule, and up to now she's controlled locally there. She has a progression on the back. This is a patient with a lymphangiosis, which I first treated 2013, verified by biopsy. After 5 treatments, a very good regression and almost complete remission. But she had in September of the same year already a recurrence outside or on the border, which I retreated again. You can here see the normal pigmentation, which are landmarks to define about the recurrence. And I have retreated her again with 5 times 4 gray. Then she was followed by her medical oncologist, and 3 years later she was referred with again large lymphangiosis of the chest wall, inside, outside, on the border. I retreated her with 3 times 4 gray and hyperthermia. Then we had to stop because she had a bladder infection and was no more coming to my department, but it was okay. The daughter called me in the November of the same year with again a progression. I retreated her again with 1 second treatment, and at the 3rd treatment this was this situation. Again she had a bladder infection, we had again to stop, and we had 2 years later again a new local progression. I treated her again with 3 times 4 gray is after first and then after the second treatment, and then we stopped, and up to now she's in remission. She's now referred for me for a supraclavicular progression again, but on the chest wall she's still controlled. So an example that we can really repeat such treatments as well. So as we'll come to the conclusion, we can say that this low-dose re-irradiation combined with hyperthermia is a very good palliation, sometimes also probably a curative method. With a high remission you can achieve, with a local control you can achieve, and the local control is of course related with the extension and the size of the recurrence and the lymphangiosis. You can do it very convenient for the patient, outpatient basis, very low toxicity. The timing of hyperthermia and re-irradiation is with this schedule very, very crucial, so you have to be sure that you are combining almost both simultaneously, and it can be repeated. And if we repeat, we can say that the same treatment schedule was followed in about 71% in this series, and we could get an additional control or stabilization of the disease within 11%, and we had no more than grade 2 side effects of this collective. And think about repeated irradiation, maybe in very extended recurrences, more than an ipsilateral chest wall, where it's lymphangiosis, where it's a cancer acquiras, where we know that we can never completely cure this patient. So any local treatment should be as short as possible, as efficient as possible, and as a low toxicity as possible. And I think this is a worthy palliation tool in case of these patients where we cannot get any definitive local control. It's convenient, it's well tolerated, with a low toxicity, and can be done on an outpatient basis, and it's also very cheap, maybe too cheap. Thank you very much for your attention.
Does anyone have any questions? No questions? I have one. How do you know that the timing is so crucial? Because in our clinical data, we don't see that.
I know, but I give such a low radiation dose that I did it always in this way, and with this timing I have this remission. I would not change it, because if I'm giving only 4 days once per week without hyperthermia, it would never work. So this we know from laboratory examinations. And we did also some radiobiological experiments with cell cultures and with time delays between 15 minutes, half an hour, 45 minutes or 1 hour, and only the combination within 1 minute with the 2 treatments worked with this 4 days. So we have some indirect proof of that.
Thank you.
You're welcome.